Hello everyone. Today's video is another Q&A video talking today about bacterial vaginosis and biofilms, talking about methylene blue possibly causing facial tics, and also talking about using low-dose immunotherapy or low-dose allergen therapy in relation to having an MRI. As per usual, nothing that I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. And if at some point during the video or at any point in the future you wouldn't mind taking a quick moment to please like, share, subscribe, and or post a quick comment on the video, I would really appreciate it. So thanks in advance for taking a second to do that. So first question here is about bacterial vaginosis. So it says, if a naturopath only prescribed me her herbal concoction without biofilm disruptor and did not prescribe antibiotics, would it still be effective in curing urinary tract infection and bacterial vaginosis? And then there's actually a follow-up question saying, also, is NAC strong enough to disrupt biofilm in UTI and bacterial vaginosis, or should it be combined with nattokinase and stratopeptidase? And there aren't any phase 2 biofilm disruptors available in my country. So thanks for the questions. To be perfectly frank, the vast majority of cases of UTIs and bacterial vaginosis that I've treated in my practice, we have not needed to go, patients have not needed to use biofilm disruptors. Normally, they're very amenable to treatment and we can clear them up without needing any biofilm disruption whatsoever. It's really the cases that are super chronic or recurring, where sometimes when they're recurring, it's maybe they're actually chronic. They're just kind of, the microbial levels are going down to the point where symptoms are not apparent, but there's maybe still some microbial overgrowth that's left behind. And so basically biofilms are going to form when the microorganisms are allowed to persist and not be disrupted, I guess, in their actions for a long enough period of time. How long does it take for a biofilm to form in a given tissue? I'm not aware of any 100% definitive evidence in that respect in a biological system. We know what happens in petri dishes, but exactly what's happening in a biological system, that's where it gets a little bit more, there's more question marks there. But in my clinical experience, I usually say if symptoms have been, or if it seems that there's been some microbial overgrowth for at least 6 to 12 months, then we're starting to get concerned there might be some biofilm component. Not to say it can't happen sooner than that, and not to say that even if it has persisted for that long, that there's definitely going to be a biofilm issue. Like I've had patients who have had, say, persistent borreliosis, also known as chronic Lyme disease. We know that the Borrelia spirochetes are very, very good at forming biofilms. I've had many, many patients, they've clearly had the infection for like 10 plus years, and they get better without needing any biofilm disruption. So that's not to say every long-standing case needs a biofilm disruptor. Did I answer this? Okay, and then I guess just so easy to go off on tangents. So much to talk about. So the question about, is NAC strong enough to disrupt a biofilm in a UTI and bacterial vaginosis? I mean, in my opinion, I think NAC and nattokinase stratopeptidase. I mean, there's some. My understanding is there's no consensus on whether NAC is a phase 2 biofilm disruptor or not. Some say yes. I say clinically I don't think it is, just because it seems to be so much weaker than the phase 2 biofilm disruptors that we use in practice. But long and short of it is that I think a phase 1 biofilm disruptor is a lot better than no biofilm disruptor if a patient has biofilms. It just might take a really, really long time to see a clinical result from that. But yeah, it's definitely, in my experience, it's definitely better to use a phase 2 biofilm disruptor. But if suddenly I had no access to them, then I would use phase 1 biofilm disruptors and just do the best that I could with those. So thank you for the questions. Let's see here. Next one is about methylene blue. So it says, can you think of a reason why methylene blue would increase facial tics? My child took Singulair nearly a year ago, which triggered a facial tic. The tic has worsened with mold exposure. I've been trying methylene blue and I noticed her tic got worse. I took her off and it went away again. I tried it again and it seemed to be helping her. She's chronically fatigued with POTS and Ehlers-Danlos syndrome, which is a hypermobility disorder, and her tic is worse again. I'm stopping it again and hoping the tic goes away. So yeah, thanks for the question. And as mentioned in every video, I can't give any direct advice for patient cases over social media. What I will say though is methylene blue can certainly trigger detoxification pathways. It can, at high enough doses, although it sounds like this question is about lower dosages, but at high enough doses, it could be antimicrobial. But in terms of methylene blue itself, exacerbating tics, like I'm not aware of a mechanism by which that would happen directly, like a direct physiological or biochemical consequence of taking methylene blue, but in terms of it, detoxifying the mitochondria, in terms of it working as an antioxidant, maybe upregulating some detox pathways, that's absolutely something that could. I've seen methylene blue along with other things that work in that way cause flare-up symptoms, especially when there's a history of mold exposure. Then if a person, one of my patients, had stored mycotoxins in their tissues, and then they start taking glutathione, methylene blue, maybe molecular hydrogen, other antioxidant supports, then it could certainly cause. I've certainly seen those things cause flare-ups of pre-existing symptoms. So I'll leave it there for now. If there's more further questions on that, just fire away. And the last one here says, would you be willing to give your opinion on this question? How far apart do you think an MRI with radiation and an LDA shot should be? So speaking about this entirely academically, of course, I'm not aware of there being any reason why an LDA shot, generally speaking, I'm not aware of any reason why we would be concerned about the proximity of an LDA shot and an MRI. With that being said, there are certain things that can change the playing field for an LDA shot and how well it works. So if there was a patient who was getting a regular LDA shot for, say, their environmental allergens, and we found the sweet spot dose, they were getting that shot like every 7 weeks, 3 months, whatever they, figured out for keeping their symptoms at bay. And then something happened where, I don't know, they say they're really gluten sensitive, and they went to a birthday party and they ate a bunch of cake and pizza and they glutened it up, and then they felt like really crummy afterwards. It's possible, and then say their LDA shot was scheduled for the next day when they're feeling crummy. It's possible that LDA shot might not actually work as well, because there's already the playing field has changed. There's more inflammation kicking around. They're kind of off their game. Their physiology is kind of like, what the heck did you just do to me? You glutened me. What were you thinking? It's possible that LDA shot might not work as well. It's even possible that LDA shot might flare them up, because sometimes that happens when the immune system playing field changes, and maybe the dose is now inadvertently too high in that kind of playing field because there's all this underlying inflammation. It's possible. With the question around an MRI, most of the time MRIs are well tolerated. They can be stressful, because who wants to go in a noisy claustrophobic tube? And then very rarely, but some folks, if there's contrast with that MRI, very rarely some folks will react to that contrast because of the gadolinium, presumably, that's in there being a heavy metal. So if a patient, went for an MRI and they were feeling really crummy from that, which again, rare occurrence, but if it happened, then that could maybe throw off the expected effect from that LDA shot. So it's, but there's nothing with the MRI procedure itself where we think, oh, that should interfere with the LDA. It'd really only be if there was a flare-up from that. So that's my 2 cents on that one. All right, I'm going to leave it there for now. Apologies for being so short on the screen today. I'm set up in a different room today. And anyways, I'm trying to get the camera figured out, but hopefully it was not too off-putting to have me be short on the screen today. I'm really very tall in person, actually. You wouldn't know it from my videos, but I'm 6'3", so quite large. Anyways, I will leave it there for now. Any questions, comments, just post in the comment section below. I'll do my best to answer as soon as I can.